Hello there, welcome to the next part of the pathology series. We'll start right away with it. We got for today congestive heart failure, ischemic heart disease, and congenital defects. My name is Musa Mustafa, and let's go for it. One more thing before we proceed. I will provide, along with this video, you'll find it perhaps as a, in the comments below or as in the description. You'll find a link to the script of this video, hopefully to make it easier for you to write notes or to sort of like review what I had mentioned regarding something, or very simply, if I ended up bumbling too much as I spoke, it's gonna probably be, you can recheck the script just to see if they're just to make sense out of what I was trying to say, because I'm just loosely following the script. The script is more like a text that you can be sure that they have. As well, it'll help you maybe stay a bit more focused, not necessarily be too distracted with writing notes. Although you may write notes, you may like download and write notes onto that, whatever floats your boat really. But yeah, without further ado, we will now continue. I'm gonna share with you something that I find is extremely important, and this is this mnemonic to help you structure your talks about any disease, period. So this is gonna be very helpful, especially in your internal medicine studies, but it's also gonna be helpful for the rest of the subjects as well. You'll be using this to just structure your talk, structure your ideas. It's more of a framework. It's more like guidelines. It's not necessarily that you have to follow it strictly, step by step sort of thing, but it is very, very helpful. However way you decide to use it. So mnemonic is deep-seated. So it goes like this: that to study internal medicine, you must remain deep-seated. So like you would be right there on that couch. So like whatchamacallit? Deep-seated. So D definition, epidemiology. Epidemiology is plus minus. You don't always have to mention it. People aren't always interested in it in a final exam, for example. Etiology. So this is the cause. Pathogenesis. So that would be the pathogenesis which leads up to the disease. Like the mechanism, basically the mechanism of how the disease develops. As well, along with this point, I'd like to mention some classification, if applicable. Clinical manifestation of the disease, it's how to diagnose it and how to treat it. And with that, you will become nicely deep-seated. You right here, and yes, this is like that. And that will hopefully help you. This will either give you like memory or it'll give you a nightmare feel, but whatever. Like that right there. Okay, there we go. So this is deep-seated, and we will use this for our structure for any disease. Okay, right now we're going to use it right away for congestive heart failure. So what is congestive heart failure? I like to always just like give it a word, like you get this way, see just line by line. It helps you focus. So what is congestive heart failure? It is failure of the pump. It is simply straightforward. Heart failure is failure of heart. It is the heart fails to pump blood to the body. That is just literally what heart failure is. As a definition, this is what it is. So next up is what would cause this heart failure. This would be the etiology. So the heart is the cardiovascular system is made of three parts: the heart, the vessels, and the blood. So the heart is the pump. It's like when you think of a system of pumps and tubes. I don't know what you call it. It's like you got the heart as a pump, the vessels are the tubes, and the blood is the fluid which goes through those tubes. Any problem in any part of these will cause you, may lead to heart failure. The thing is that heart failure is failure of one of these parts, but the thing is that the common endpoint of all of these parts is a heart problem. So like a heart problem will lead to a heart is a heart problem. Okay, of course. A vessel problem will cause is a problem which will cause problems for the heart. And so it'll lead to a heart problem, and the blood problem as well. It is a problem which leads to a heart problem. So examples here are so direct heart problems is ischemia to the heart. So like a heart attack. So ischemia is ischemia. Isch is poor or decreased, and emia is blood. So decreased blood. So decreased blood flow to the heart. When the heart doesn't get enough blood, so it's, the vessels of the heart are clogged. We'll get to that in a bit. The vessels of the heart are clogged. The heart isn't getting its nutrition. It dies off. and then it won't be able to pump blood properly. So that is ischemia. Other problems are, we'll go through this quickly and then show them. So you've got as well valve disease, problems with the valves of the heart. I'll show that on drawing. The next point is cardiomyopathy. What is cardiomyopathy? It's a specific disease that the heart can develop. Basically, the myocardium itself has some sort of problem. It's like some poorly understood reason as to why it develops, but basically there's a problem with the structure of the muscle of the heart, or it's the muscle of the heart has become stiff, fibrosed for some reason. There are these are examples of what is a cardiomyopathy. It is its own entity, it is its own disease, but it is a specific and separate thing. That is another a heart problem that leads to heart failure. Just about this point of valve disease, so stenosis or insufficiency. So this is a heart right here, okay? And the situation right here is that in this heart, got it right here, this is right heart, left heart, okay? This is the right atrium, right ventricle, left atrium, left ventricle. So the valves here, let's take here, these are the atrioventricular valves, so the valves between atria and ventricles. All this is probably obvious for you. These are the AV valves right here, and these are the valves of the Greek vessels. So this is the aortic valve, and this is the pulmonary valve. So this is the pulmonary artery, this is the aorta. Aortic artery, let's go. This is the aorta. Anyways, so a problem with these valves will lead to heart failure. How so? So there's two problems that can happen, whether it be stenosis or insufficiency. Stenosis means the opening is too narrow. So like instead of the opening is as wide as it is now, let's say it's like some fibrosis is happening, and you just got a very small opening. This is going to lead to this is going to lead to blood gorging up too much in the atria, and it's not getting to the ventricles. So and this is one form of heart failure, that the blood is now over here and it'll start backing up to the previous zone. The blood is building up in the atria. It builds up so much to the point that it can't take anymore, and it'll then end up going backwards, back into a previous zone. So the previous zone before the left atrium is the pulmonary circulation. So it'll end up the blood will be congested to the lungs. We'll get to more information about this congestion, etc., in a bit as we go on. But this is the example of a valve disease. The other point is is valve insufficiency, when the valve isn't closing properly. So like say the same valve, let's just change and make the aortic valve. Say if the aortic valve isn't closing properly, like you know how the heart cycle, how when the heart contracts, when this ventricle it contracts, the valve opens due to the massive increase in pressure, and the blood bursts out of the aorta and goes to the systemic circulation. Then after this after the heart has finished pumping, finished contracting, the ventricle has finished its contraction, is then gonna relax. It's gonna relax, and when it relaxes, this valve, the aortic valve, is supposed to close. Okay, if it doesn't close, it's called insufficiency. And when in this insufficiency, some of the blood will be able to get back to the ventricles. This becomes a continuous problem where the blood keeps on getting back, and in each contraction there will be some residue, and the ventricle will keep getting bigger and bigger until a point where the heart gets tired. It is not able to pump all that blood, and it fails. This is a simplified version of valve diseases. Yeah, I didn't check. I think actually you'll have more of an explanation, quite possibly, regarding this in the next part of cardiovascular pathology series. So, I made it easier for the next person that has to present. You're welcome, whoever you are. Anyways, so as we left off, so you have ischemia, valve disease, and cardiomyopathy are some cause of some heart problem causes. So next is vessel problems, so hypertension and blood problems is like anemia, polycythemia. So blood problems aren't that, like, it isn't a very common cause of heart failure, but I'll go through it. I'll go through it anyways. But first off, what is very important, is vessel problems. So vessel problems, let's go back to this drawing right here. The vessel problems, say the aorta wants to, like, what if you wanted to pump blood to the body, but the body said, my pressure is too high. So if, like, you know, if you remember from physiology, the whole situation of preload and afterload. So like afterload is like what the heart has to pump against, like the pressure that the heart has to pump against. So like if the systolic blood pressure is normal, say 120, okay, the heart is gonna be able to pump blood to it. Say if the blood pressure is like 180 or something like that, the systemic blood pressure, it's gonna be exponentially harder for the same ventricle of this size to be able to pump blood to this body with this pressure. It's just too hard. It's more work on the heart. So this increased work, this increased pressure. So this is a valve disease. This is a vessel disease. Hypertension is a vessel disease. So in this vessel disease, it causes an increased pressure demand on the heart, or an increased like work demand on the heart. The heart has to generate more pressure, i.e. has to use up more work, has to do more work, you know. And since the heart has to do more work, it might get, like, I'm just gonna say in the simplest way, it might get quote unquote too tired and it's not able to provide that much work and it fails. But the actual way, that some more details upon regarding how that is or how that plays out will be mentioned soon. So that is like an example of hypertension. So this is systemic hypertension. The same thing happens in pulmonary hypertension. So the limit for the systemic circulation, where we start calling it hypertension, is about 140. Beyond 140, we call it hypertension, systemic hypertension. This is, of course, systolic blood pressure, 140 over 90 or whatever. The diastolic, no one really focuses on it much for whatever reason. But anyways, systolic blood pressure above 140 is typically known as systolic hypertension. Pulmonary hypertension starts at like 30, about 30 millimeters of mercury, and same idea. Like the pressure is too high, the heart has to do more work against this high pressure, and so it is quote unquote exhausting for the right heart, and so the right heart will eventually might give up and not be able to pump against that much blood. I will soon explain about more in details about all these quote unquote like gives up or whatever. We'll get to that in due time. But starting off, we'll first continue where we were going regarding congestive heart failure. So, like we mentioned the definition of congestive heart I'm just gonna call it heart failure from now on. Congestive is just a side point. So heart failure, it is failure of pump. Like we mentioned, heart can't pump blood for whatever reason. The parts that can flop it are either the heart, the vessels, or the blood, but all in all, it always ends up as a heart problem. Like the ischemia, valve disease, and cardiomyopathy are directly heart problems. The vessel and blood problems lead to a heart problem, so it all ends up as a heart problem. Like, you know, it leads to the heart not being able to pump. So it all leads to that initial definition of heart failure being failure of pump. Yeah. So failure of vessels, failure of quote unquote, I don't know, failure of blood leads to failure of heart. Yeah. Just side points on this: anemia and polycythemia. Again, not very important, but basically when the blood is thicker in polycythemia, so there's too many RBCs. When the blood is thicker, this requires more work on the heart, more work demand. If the heart isn't able to fulfill that demand, you will thus again lead to heart failure. Again, back to this definition of the heart failure is heart is unable to pump enough blood to meet the needs of the body. So yeah, thick blood. If the heart isn't able to move that blood, thick blood properly, then you've got it may lead to heart failure. And yeah, anemia is more of a convoluted sort of way that it works, but basically you're pumping the blood, and the blood is getting to the organs, but the organs are still screaming because they're not getting enough oxygen. So the organs signal to the heart is that, yo, what you doing? Like, this isn't enough. And so this is like this can also lead to a quote unquote sort of like heart failure. Like, you know, so though, but these are not as focused on what is what is of key importance is definitely these two, the vessel problems and the heart problems, because, and especially the vessel problems are a big thing, because hypertension is one of the most, if not the most, prevalent disease worldwide, like, you know, and it is such a massive problem, and it causes such massive issues, and it's just not, you just can't detect it. Nothing shows in hypertension up until it's too late to treat. Like, you know, I guess you'd probably, I think, did they cover hypertension in the previous pathology series? I would hope so, because it was vascular pathology last time. So yeah, that is hypertension. And that is, that right there is, that right there is the etiology. So we've covered definition, so deep-seated again. Definition, epidemiology we spoke, sort of. Etiology is not really the point. Etiology, now pathogenesis. So pathogenesis of heart failure. Look at it, I'm just doing this in such a getaway but allowed. Anyways, so pathogenesis. What is the mechanism of heart failure? How does heart failure develop? Is like the step-by-step mechanism of what, like how the heart failure develops, and what this heart failure leads to, like, yes, a step-by-step of what it leads to as well. So first off, I'll just move a bit more so that I know actually what I have to say. So the heart failure leads to changes inside and outside the heart. So like, so first off, changes within the heart, like changes of the heart itself, that result from heart failure, which is failure of the heart as a pump. When the heart fails as a pump, there's a few things that could happen. And option one is dilatation. Okay, so basically how it works is that I'll just read them fast: dilatation, hypertrophy, and decompensation. Okay, so back to this drawing of ours. An example of each of them: dilatation, hypertrophy, and decompensation. So dilatation happens in an acute setting, okay? When all of a sudden there's a problem with the heart. It doesn't have enough time to do anything about the heart failure. So like, for example, in a heart attack, and we'll cover more details about like heart failure in a bit. So in a heart attack, so like myocardial infarction, there's gonna be all of a sudden dying of a part of the heart, part of the muscle, okay? When the part of the muscle is not able to contract anymore, the heart is now weaker. When the heart is now weaker, it's not able to get as much blood out, and so more blood pools into the heart. And so, since it happens so suddenly, the heart doesn't have anything to do about it, and just the ventricle just dilates, okay? It gets bigger, like sort of like a balloon, okay? Like it's gonna be very thin, like this thickness is gonna be stretched out, and it's gotta be more like something like this. Imagine, like a very thin wall, okay? So what this will lead to is the blood pools into the heart, and most likely you are dead now, because the blood isn't like, the heart is now floppy. It's not able to get the blood to where it needs to be. The brain is gonna run out of like nutrients, oxygen, and it's gonna die, and you're gonna die. So that is dilation or dilatation, and again, once again, it happens all of a sudden, and heart doesn't have time to react to it. What if it happened a more insidious, a more chronic process, a more slowly developing process? So this would be, for example, maybe an aortic insufficiency, which doesn't develop sudden, like aortic insufficiency can be acute, can be chronic. So let's say some form of like chronic aortic insufficiency, okay? So like chronic, i.e. long-term, aortic insufficiency, i.e. this valve isn't working anymore properly, so that blood is sometimes seeping back in, and as the blood seeps back in, the ventricle slowly has more residual blood, and this more residual blood increases, plus the regular blood that you're getting in. So now, instead of like having 100 milliliters, whatever, I'm just gonna use random numbers. Instead of having to pump just 100 milliliters of blood, you're gonna have to pump 110 and then later 120, 150, 100 to 190, 200, and it's slowly developing. Because it's slowly developing, the heart has time to react to this. It's like, hey yo, boss, I got more blood to pump now, so like I gotta do something about this. So what the heart does is literally like working out. The heart is now quote unquote working out, and it's like a biceps that gets bigger. The muscle, the heart's quote unquote biceps get bigger. So like the heart wall, the wall of the heart itself will get thicker. So this same wall, just a continuation of this wall, and it'll get thicker, like, you know. So this thick wall is like, and it's like pump, like pew, like that. So like what will happen here is that the heart is able to compensate. This is an adaptive mechanism. It's called hypertrophy. Hypertrophy of the heart. The heart has thus compensated to the situation. Yeah. The same situation is a similar situation happens in hypertension. So hypertension, blood pressure 190. The heart has to work against a heavier load. So if this happened all of a sudden there's like, I don't know, like blockage of this artery of the aorta or something like that by some mechanism, it would be too fast and dilatation would happen with thin wall and you're dead, okay? Because there's no time to react. But what if like it was a more chronic insidious process like hypertension, like systemic hypertension? You're not taking your medication, you're eating too much salt, whatever, and your blood pressure is increasing, and you're getting into stressful situations, whatever, it's ranking up, and you got blood pressure instead of 140, it's now 190, okay? So the heart has to work against an increased load. Because it has to work against this increased load, so like it's like when you go to the gym and you're used to lifting like let's say 140 kilograms of weight, whatever, okay? And then slowly we are increasing that weight to like 150, 160, 170. Your muscle will start to adapt and it will get thicker, and instead of being like you'll have your biceps will be thicker, basically, and that is the analogy I'm trying to give. It's not the most accurate, but it works. The thickness of the heart muscle is thicker, and it's now dealing with that increased pressure demand. There's an increased pressure demand, and yeah, so that is the situation, and you got hypertrophy. Hypertrophy is an adaptive mechanism. It is a compensatory mechanism. It will keep on working. It will keep on doing its thing up until a certain limit, when the pressure is just way too high, and even though the heart muscle is very thick, it's just not able to get any thicker, or it's just not able to meet that demand. What happens is called decompensation. So it was compensated and now it's decompensation, and what happens now is that like the heart has reached its limit, and now the heart begins to dilate. It was hypertrophied, and now it's both hypertrophied and dilated, so it becomes something like this, like, you know. So yeah, so just to summarize, I really hope that was a clear explanation. I'll give you all the time you need if you need to review what I just covered. Like, you can repeat it as many times as you like. I promise I won't get tired, because you know it's recorded. But whatever. Back to the point that I wanted to check back. So that was dilatation is when it happens too quickly. Okay, it's an acute problem. Too much blood pools into the ventricle, for example, too suddenly. Okay, now you got too much blood to deal with, and the ventricle is just it can't handle that. It doesn't have time to adapt, and so you have sudden failure of the heart, and acute heart failure and sudden death. Like, that is the situation. Hypertrophy is when the heart has enough time to react, and so the heart becomes thicker and thicker, stronger and stronger, fighting against that increased pressure, and so this is the hypertrophy. And decompensation is when the heart reaches its limit. It can only do so much before this adaptive mechanism can't do any more, and you have like a decompensation, a heart failure. So in this one, you'd have a very thin wall, but like a big wall, but it's very thin. Hypertrophy, you'd have normal size of the wall, but it's very thick. And decompensation, you'd have a very big or a very big wall and a very big and thick wall. Yeah. And so jumping straight to the next point, we're going to now cover what's known as forward failure and backwards failure. These are the changes which occur outside of the heart. We covered already the changes which happen within the heart, like to the myocardium of the heart. Basically, the thing that happens acutely, the thing that happens chronically, and the thing that happens chronically after the heart's adaptation mechanisms are exceeded. It cannot go beyond it. And so now we're going to cover the changes outside of the heart, and these include a forwards failure and a backwards failure. So what is forward and backwards failure? So I'm just going to take this picture. Where is it? Yeah, there we go. So forward failure and backward failure. So let's say we had let's say that someone had a myocardial infarction. Okay, left ventricle is flopped up. Okay, what occurs is that now the left ventricle has a problem not only pumping the blood forward, which would be known as forward failure. So what does forward failure mean? It means failure to pump the blood forward to the next section of the body. Okay, failure to pump the blood forward to the next section of the body. So that is forward failure. What's the other thing that happens? Simultaneously, you will have what's known as backwards failure. It is failure to take blood out of the previous section of the body. Failure to take blood out of the previous section of the body. The previous section of the body before the left ventricle or the left heart in its entirety is the pulmonary circulation. So blood will become, now's the word, congested in the pulmonary circulation. So that's why they call it congestive heart failure, because there's congestion in a section of the body. And so with congestion of the blood in the pulmonary circulation, you have increased blood. These capillaries, the capillaries of the pulmonary circulation become dilated. They become filled with blood. Normally, you're supposed to have a thin wall and not much blood going through the capillaries, and oxygen exchange occurs. But when there's so much blood and it's engorged with blood, because of this increased hydrostatic pressure, some fluid will seep out of the capillaries, and this is known as pulmonary edema. And it is the hallmark feature of backwards failure of the left heart. Okay, so that is that right there is pulmonary edema. Pulmonary edema is basically you have now fluid which has escaped into the lungs, which is causing an impairment of oxygen exchange in the lungs. Because before you had just it goes like that. You got the alveolus, you got the capillaries, the capillary that is around the alveolus. Now you have this space used to be thin. Now it's thick and thick in the sense that it is wider and is filled with edema fluid because of the engorgement of these capillaries, increased hydrostatic pressure. Fluid escaped over here, and now the oxygen has to not only it just had a short pathway that it needed to cross, and now it has to cross wider than that. And so this is now causing a problem with breathing. It's gonna cause dyspnea, etc. Yeah. So that is an example of forward failure and backward failure. Yeah. So once more, forward failure is failure to pump blood to the next section of the body. Backwards failure is failure to pump blood away from the previous section of the body. Yeah. So after having spoken about forward versus backwards heart failure, the next part that can be spoken about is left versus right heart failure. And basically, we spoke already about how forward failure is you can't pump the blood into the next section, backwards getting the blood out of the previous section. Left and right is basically, whether this is happening to the left part of the heart or the right part of the heart. So we already gave an example of the left part of the heart and the pulmonary circulation. Similar thing can be said about the right part of the heart, in which the blood the forward failure of a right heart would be you cannot pump blood into the pulmonary circulation. The backwards failure of the right heart would be you cannot pump blood out of the systemic circulation. Yeah. So when you can't pump blood out of the systemic circulation, blood will congest throughout the body. And what does this represent? Blood will be congested throughout the body, except for the lungs. The lungs will be spared in this situation. Okay. So real fast. So what would be the manifestation of this? What is the first organ right behind the right heart? That's a question for you. Think about it. it is the liver right there. Like not above the guy's head, yeah, but it's like right, like you have just the diaphragm right there, and the liver is very close. Inferior vena cava is right next to it, like the liver is then draining it near it. That is the liver. The first thing affected is the liver. And anyways, so what happens here? What happens is basically there's a few steps. This whole process is known as venous stasis. Okay, when blood sticks around in the venous system, just like how we spoke about here, when blood was sticking around in the venous system of the lungs. When you speak about venous stasis in any other part of the body, so venous stasis in the liver, one thing that will happen is that this blood, it's venous, so it's not. It is deoxygenated. Since it's deoxygenated, therefore, slowly but surely, the tissue with blood congested in it, it will eventually start to slowly die out, and that's exactly what happens. For example, in the liver, what will occur to it is known as cardiac cirrhosis. So cirrhosis is the fibrosing of the liver, fibrous degeneration of the liver. This is called cardiac cirrhosis because it is the result of the cardia from the heart. So this problem with the heart will lead to these fibrous changes in the liver. It starts off as steatosis, which is like these fat lobules building up in the liver, which then develops into cardiac cirrhosis, which is a full-on fibrosing of the liver, which develops with time due to this blood congestion, due to this poor oxygen supply, due to blood sticking around there, venous blood, deoxygenated blood. So, other than the liver, you've got every other part of the body. So you've got the, well, all over the body, really. You have edema, and this starts off in the lower limbs, typically, because of gravity. It'll start off in the lower limbs, typically around the ankles. It is most visible, and what the person will typically first complain of when they have these symptoms of right heart failure, backwards failure, is that they'll say that, oh doctor, I can't put on my shoes as easily anymore. My shoes don't fit anymore because their feet are swollen. Because their feet are swollen, their same shoes won't be able to fit. So this is this typical foot swelling or swelling around the ankles most frequently. It starts like that. So the feet are swollen, and likewise, the swelling continues throughout the body. Likewise, there will also be fluid in the various cavities of the body. So in the peritoneal cavity, you'll have ascites. In the pleural cavity, you may also develop hydrothorax, and you might even, although it's less common, you might develop hydropericardium, but that's not very common. So the most common by far is definitely going to be like edema and ascites. And same idea applying here. It's a transudate, so basically the blood transsudes into these cavities as the peritoneal cavity. So it's a thin fluid. It is not a proteinaceous fluid. It is a thinner fluid, and it ends up in the peritoneal cavity. By thin, I mean like basically it doesn't contain like proteins, etc. It is a low protein fluid that seeps into the peritoneal cavity. Moving swiftly on, this is very deeply, as you've noticed, this is very deeply connected to the clinical features, because so far, as we've been speaking about forward versus backwards, left versus right heart failure, this is what a patient will also present with. Like the manifestation of heart failure will always be what is known as venous stasis, okay? So blood pooling somewhere, literally, this is it. I'm just gonna write here, like, yeah, equals blood pooling somewhere, yeah. Somewhere. So that is what venous stasis is, and we spoke a little bit about that. So and so, as you see, for the most part, we've already spoken about the clinical manifestation of left and right heart failure, which is basically venous stasis. But just one thing, to cover a few blind spots that I may not have covered. So first off, something regarding acute versus chronic left heart failure. Acute heart, we already spoke about, like, you know, decompensation, blah blah blah. Yeah, we spoke about that. decompensation being the acute manifestation, and hypertrophy being the chronic and the manifestation. One other thing about the features of a heart failure which develops acutely versus one which develops chronically is that and this is just a minor sort of pathoanatomical point, that in an acute left heart failure, you will have the lungs become spongy, full of fluid, like we've already explained, and this is leading to pulmonary edema. However, in a more chronic setting, the lungs will slowly absorb the fluid. And as well the chronic congestion of the lungs and the chronic congestion of the capillaries of the pulmonary system with blood will lead to a sometimes escaping of red blood cells into the alveoli. This will cause macrophages, which are chilling in the lungs, to eat these red blood cells. They become siderophages, and a person may cough out these cells later on. And this is known as a bronze sputum, or also known as sputum crotium. It's a bronze sputum, and the cells he's spitting out in the sputum are known as heart failure cells. These are cells which are present in a chronic left heart failure in which the red blood cells have escaped through the chronically congested capillaries of the pulmonary system. The macrophages ate these red blood cells, and the hemosiderin from these red blood cells, or the iron of these red blood cells, they have become siderophages, and they are plump brown and bronze cells, and dude spits them out, and they are known as heart failure cells. Anyways, so that is this concept of chronic. This is the concept of sponges full of water. This is what this meant. Brown in duration is basically, so like I said, is that the brown comes from these the heart failure cells, the RBCs escaping into the lungs, and as well the lungs having a chance to resorb some of the fluid, and so and as well some collagen fibers, etc., forming due to this chronic thing that is going on. It will lead to the lung becoming more firm. So in the morgue, like when you check the guy's lungs, in an acute status, the lungs will be like sponges full of water. You just cut them open and they just gush out water, edema fluid. In chronic heart failure, these lungs will be more firm, more brown, like the more brownish bronze. Yeah. So the last part to mention is regarding the clinical features. We've already mentioned some of them, but we just spoke generally that dyspnea is going to happen. I'm just going to do the usual thing I do about it. So yeah, just to keep you focused. We already spoke about dyspnea as a result of left heart failure, but because of the fluid which is in the lungs, this is more of a dyspnea on exertion. Actually, when the person is tired and when the person is needing that extra oxygen and he's not getting it because oxygen exchange is more difficult, the person starts gasping for air, and that is this dyspnea on exertion. There's also orthopnea. Orthopnea is that when the person is lying down, more of the blood which is in the lower limbs, etc., will now get to more easily get back to the heart because of now gravity is not against it so much. So the guy used to be like this, and so blood is in the lower limbs because gravity. But now, because the guy is like this, gravity is not keeping the blood down anymore, so it's getting back more easily. It is now surface level, and so blood is getting more easily back to the heart. More blood back to the heart means more blood in ending up in the failed ventricle, or trying to get to the failed ventricle, failing to get to the failed ventricle because the backwards failure, and so you have more blood pooling in the lungs, and so you have difficulty breathing while lying down, orthopnea. And so such people, like people with chronic left heart failure, tend to sleep with extra pillows. They need extra pillows to sleep so that they be reclining like this instead of being like this dude over here. They'll be reclining like this when they sleep so that it's more easy for them to breathe. Paroxysmal nocturnal dyspnea is a similar thing is very similar to orthopnea, in which at random times at night, when the guy is lying down, he will have dyspnea because, yeah, the same thing. It's nighttime, he's sleeping, and he wants oxygen. He can't get oxygen so easily because fluid fills his lungs. Crackles is a physical exam finding on auscultation. Crackles on auscultation is because, well, there's fluid in the lungs. Crackles are those, those popping, bubble popping sounds, discontinuous, like sort of sounds, on auscultation. This is the opposite of wheezing. Wheezing typically happens to the in a pathology of the bronchi, where it's more of a whistling musical sound, like wee. Okay, so that is wheezing. Crackles is more of a bubbling sound, like that, upon auscultation. So that is that so far. So this has been left heart failure as a whole. So we've spoken so far about previously we've spoken about its etiology, its pathogenesis, some classifications, etc., its clinical features, and now swiftly about right heart failure. So the causes of right heart failure is pulmonary hypertension and anything that causes it. Okay, so anything that causes the pulmonary circulation to have increased pressure. So anything that causes pulmonary hypertension has the potential to cause right heart failure. So some examples of this, let me give you some examples. We've spoken a bit about these points. So let me give you an example. So some causes of pulmonary hypertension include, for one, lung disease like COPD, chronic obstructive lung disease, COPD, chronic obstructive pulmonary disease, whatever, and any other, like many lung diseases, so as well like pneumoconiosis, like silicosis, etc., even as well post-pneumonia or post-TB. All of these are diseases of the lung. They can all cause an increase of pulmonary arterial pressure, so leading to pulmonary hypertension. So what I wanted to highlight is, for example, in COPD, chronic obstructive pulmonary disease, you've got a general state of hypoxia all throughout the lungs, okay? So this generalized hypoxia, perhaps you remember it from physiology. When you have a local hypoxia, all right? So let's just do this right here, all right? This is some alveoli, okay? Okay, so here's some alveolar, okay? So if there's decreased oxygen in one alveolus, the vessels, particularly the arterioles, the sphincters of the arterioles, leading up to such a hypoxic alveolus are gonna constrict. Okay, constrict so that the blood stops going to a poorly oxygenated alveolus, so that it can be shunted away to a more oxygenated alveolus, like our friend here. This is like a normally oxygenated alveolus, and the blood will end up going to this fellow right over here instead of this fellow over here. That's great, but what if all the alveoli, all of them, allow my drawings, don't worry about them. So what if in all the alveoli you had a generalized decreased oxygenation? Okay, so because this mechanism, this adaptive mechanism is amazing. It is amazing for dealing with local problems. But in generalized problems, what happens when all of these have decreased oxygen in them? All of them have decreased oxygen in them. What happens is that you have vasoconstriction in all of them. So when you have the whole lungs, like all the lungs, all the alveoli of the lungs are all vasoconstricted, the blood won't just not go there. No, it will be forced to go to, like, throughout all the lung through constricted vessels. This is more difficult on the right heart, and this is like an increased pressure in the entire pulmonary vascular system, and this is known as, guess what, it's known as pulmonary hypertension. And so with this pulmonary hypertension, you have more work demand on the right ventricle, and the right ventricle isn't used to putting up so much work. And so in COPD, in a chronic COPD, you may have development of right heart failure. Okay, so just another point here to mention is that when a heart failure, when right heart failure is the direct result of a lung pathology. Let me repeat that. When a right heart failure is the result of a lung pathology, it is known as cor pulmonale, literally lung heart. Okay, lung heart. Cor pulmonale, cor heart. Pulmonale, lung. So cor pulmonale is a lung heart, basically. Cor pulmonale is a right heart failure resulting from a pulmonary pathology. Okay, so that is that, and so cor pulmonale, right heart failure. Another possibility, one more lung disease I forgot to mention, is pulmonary embolism. Okay, pulmonary embolism is when you've got some embolus, which typically develops in the lower limbs, typically like calf, deep veins of the calf, like a thrombus develops there because venous stasis in the area. Person's like sitting, like standing for too long or sitting for too long, whatever, or they're just immobile for so long. They've had surgery, they're pregnant, whatever. They had surgery, they're immobilized for 3 days on a bed, not moving, and so because of Virchow's triad, you have stasis. This stasis will lead to an increased coagulability. So we have the coagulum developing in the lower limbs, and with a wrong movement or something like that, the thrombus lunges out and ends up in the right heart, and may end up going to the lungs. If it's a massive thrombus, it might end up blocking a large part of the pulmonary circulation, and the person's all of a sudden going to drop dead because of massive increase of pulmonary vascular pressure. The right heart won't be able to handle it, and give it a second, what kind of change will happen to the heart? Tick tock, tick tock. An acute change of pulmonary pressure. This will lead in an acute change of the heart, and this is dilation of the right ventricle and acute right heart failure, and the person drops dead. They are not able to get blood moving. The whole system just fails. Yeah, so that is an acute right heart failure. But what if the thrombus was very small and it only ended up lodging in like one of the smaller capillaries, one of the smaller parts of the lung vessel, or a few of them even, like let's say a bunch of thrombi over the years, 1, 2, 3, just a few of them. Like, so what will happen is it's the same thing, but it's gonna be more insidious, much more insidious. The person won't drop dead. It'll be more. It'll be instead a case of pulmonary of right ventricular hypertrophy instead of dilatation. Yeah, so this will be the same thing exactly, but instead of a massive thrombus, you'll have a smaller thrombi developing much slower, like over the course of years, etc. So the person might not develop symptoms very clearly. It might just develop a bit of dyspnea, etc. But the process is going to be a lot slower. Yeah, so that is pulmonary embolism and deep venous thrombosis, just in a summarized way to explain this point of heart failure, of right heart failure etiologies. So we've spoken so far about pulmonary diseases, about as well we mentioned now pulmonary embolism. We mentioned this concept of possibility of acute and chronic. The other point I wanted to mention is that so far we've been speaking about left heart failure, right heart failure, okay? The truth of the matter is that it's typically not like this. It typically does not play out like this. The only example of an isolated heart failure that typically happens is cor pulmonale. Cor pulmonale is an example of an isolated right heart failure. And this is a typical example of an isolated. But typically, they're not isolated. Typically, clinically, you'll always have them together. Outside of the realm of cor pulmonale, you'll always have them together. So because a left heart failure will eventually lead to a right heart failure. So a left heart failure will lead to a right heart failure because a backwards failure of the blood in the left heart, backwards failure will lead to congestion in the pulmonary system. This congestion in the pulmonary system, increased pressure here, increased pressure there, blah, 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 backwards failure all the way into the right heart. Yeah, and the right heart won't be able to handle it. It congests in the system. Yeah, so if you have a myocardial infarction, while the first symptoms may be dyspnea, the symptoms may very well develop into liver problems, into edema, into ascites. Yeah, so this is perfectly normal. Yes, so that is almost everything. Next, for heart failure, we just jump to the diagnosis and the treatment. So how do you, and this is basically typically just for internal medicine. You won't need this so much for pathology, but it's still helpful. So how do you diagnose it? So there's the labs. The labs are basically like, blood test. In a blood test, you'll have an increase of BNP, brain natriuretic peptide. It is basically it is a hormone which is released from the atria when the atria are distended. Okay, the atria are stretched. They release this hormone. It affects the diuresis, and it's supposed to help get the fluid out of the body. So it's like a thing which is supposed to reduce the intensity of the heart failure. X-ray as well, you're gonna have a fat heart on X-ray, like cardiomegaly they call it. It's like a normal X-ray, blah blah blah, and you just have the heart which is quite big. The other example is another way to diagnose heart failure is echo, which is a heart ultrasound. These are all just diagnostics, like laboratory and imaging diagnostics. Of course, diagnosis always starts with history and physical examination. History and physical examination always know this first very well. Yeah. It is not true when they tell you, hey, physical examination is not very important because, we already have imaging methods, and imaging methods are way superior. Okay, so I've never had an ultrasound. I don't think any of y'all have a handy ultrasound in your homes that you use every afternoon, like after lunch. You just do an ultrasound. You get me? Is that basically physical examination and history is the first line, is the first thing that checks up on these things, and that tells you that something is wrong. When a person first comes into your clinic or whatever, your first thing you're going to do is history and physical exam. You don't instantly give an ultrasound to every part of the body, give an x-ray, give a CT. That's nonsense. Yeah. So physical exam and history and physical exam are first, and then when you have suspicions, you move to the next steps. Yeah. Anyways, that's just a side point, because if I'm going to be speaking about stuff, might as well increase the benefit. Anyways, treatment. There's two levels of treatment. We've got ACE inhibitors and diuretics. I know that this is for a person who's not covered pharmacology or internal medicine, might be a bit strange for them, but hear me out. It might still be beneficial for you. Because this is going to be pathophysiologically important as well. So remember how, for example, in left heart failure, we spoke about, we focus mainly on backwards failure, because backwards failure is the main, clinically presenting thing. It's the main thing that you find clinically. You see a patient not able to breathe. You got the patient who is, can't wear their shoes because they're edematous, etc. But forward failure, there is an importance to it, indeed. Because forward failure, when there's decreased ability to provide blood to the periphery, one of the organs which are affected is the kidneys. The kidney, that's a massive kidney. Okay, kidneys. The kidneys aren't getting enough blood. When the kidneys don't get enough blood, what will happen is that they will, their quote-unquote alarms will go off. Sort of revise a bit of physiology, a bit of pathophysiology. You'll get what I'm saying. That when the kidneys have decreased blood flow to them, you have the triggering of the renin release, and renin, renin goes on. Actually, renin, angiotensin, aldosterone system. Yeah, RAS, the RAS system. The RAS system is triggered because of this low oxygen and low blood supply to the kidney. What this will lead to is volume retention, because aldosterone causes decreased urination. Because the kidneys, when they're receiving less blood, they think, hey, my boss is bleeding out to death. This is what they detect. This is what they perceive. They don't think that you had a myocardial infarction and your heart has failed. No, rather they think that you are bleeding to death. And so what this is one possible understanding of how this the reason of how this plays out. And so the kidneys ramp up this RAS system. The RAS system causes fluid retention and hypertension. So it'll cause hypertension, so it's going to be even harder to pump blood to the periphery, and also it's going to cause increased volume of fluid, and you don't want more volume in heart failure, like, you know, so it's gonna be more fluid that you have to deal with. So an increase in afterload and an increase in preload, and so this is going to be even more difficult for the heart. So this is where ACE inhibitors come in. ACE inhibitors antagonize this whole the RAS system, and so when you have the RAS system turned off, you have this whole downward spiral prevented. Yeah, it also decreases blood pressure, so it's easier for the heart. And it also has another property in which it prevents cardiac remodeling, or it decreases cardiac remodeling. Cardiac remodeling is basically pathological changes in the heart. ACE inhibitors help prevent these pathological changes. Okay, ultra vague, allowed. Okay. Anyways, so diuretics is another thing that could be used. It's basically drugs which make you pee more, and to pee out all the extra fluid. Or like to pee out as much fluid as you can, so that it becomes easier on the heart. Because last time when we mentioned about ACE inhibitors, we mentioned that volume retention. This volume retention leads to this volume retention leads to it being harder on the heart to pump out this excess of fluid. Now we just use diuretics to get rid of this excess of fluid. Yeah, so these are your treatment options. So basically, just for those who haven't studied internal and pharm yet, just as a heads up for you, everything above was mainly pathology, and just this slide alone is the single slide you would add to internal medicine, almost in its entirety. Like, you know, internal is not a very scary subject. It's quite a nice subject. Look forward to it if you haven't started studying it yet. Yeah. So that was a quick, not quick run. That was a very long run across heart failure. Surprised that it actually took that long. I probably stuttered way too much. I'm sorry. Regardless, I hope it was beneficial for you. This has been just the first slice of cake, and now we're gonna run through the next parts. However, I was like, okay, quick summary of what we've covered so far. Definition: failure of pump. Epidemiology, not very important. Etiology, basically is going to be a heart problem. It's going to end up being a heart problem. Most likely is going to be hypertension or something that increases typically the pressure of the system that the blood is trying to the heart is trying to pump blood to. So either pulmonary hypertension or systemic hypertension, or some sort of ischemia, valve disease, whatever. Pathogenesis, we spoke about classification, we spoke about pathogenesis of dilatation, hypertrophy, and decompensation. We spoke about forward and backward failure, depending on where the blood, like you can't push the blood forward, or you can't take the blood out of the backwards, or out of the system, the section that is behind the heart, that part of the heart. We spoke about left heart failure versus right heart failure, where left heart, you typically have dyspnea, orthopnea, paroxysmal nocturnal dyspnea. And right heart failure, you have typically ascites, edema, liver problems, appetite problems because swelling of the mucosa, generalized swelling of the body. Yes. And then we spoke about the diagnosis, so BMP, X-ray, echo, and we spoke about the treatment, so ACE inhibitors and diuretics. That is conclusion, heart failure. And now we start with ischemic heart disease. So what is ischemic heart disease? It is ischemic. It's low blood, poor blood. Isch means poor, emic is blood, so ischemic heart disease. So it is a group of diseases which leads to poor blood flow to the heart. It is a mismatch between supply and demand of the heart. It is a mismatch between supplying the heart with blood and the demand of the heart with blood. So, for example, when you have a decreased supply of blood to the heart, this is going to typically be caused by and we'll speak about the etiologies in a second, coronary artery problems, right? Yeah. So typically, the coronary arteries which feed the heart become clogged. Okay. When these become clogged, the heart dies off because there's not enough blood to support it, not enough nutrients, not enough oxygen. The heart muscle dies off. So that is a decreased supply. As for an increased demand of the heart, this would be an example of, for example, in hypertrophy. Do you remember when we spoke about hypertrophy? So when the cardiac muscle gets thicker, it becomes hungrier for oxygen. That's why when there is systemic hypertension. So when you've got, let's just get a picture just so that you don't, like, you know, I don't know, like fall asleep or something. Like, yeah, okay. So when there's systemic hypertension, all right, hypertension over here, the heart will slowly get, ventricle will slowly get thicker and thicker, and with this thickness comes an increased demand for oxygen. This increased demand for oxygen increases its sensitivity towards ischemia, because even a small drop in blood supply will lead to, like, the very hungry guy starving, you know. So anyways, another point here which is interesting is that hypertension not only causes this increased sensitivity of the myocardium to ischemia, because it's now hungrier for oxygen, because it's thicker, it has more demands for oxygen, but also hypertension is a risk factor for atherosclerosis, if you remember from the previous section. Hey, I sure hope the previous person who covered the vascular pathology did well, because like quite a few of my topics depend on that guy doing well. Alrighty, regardless. So hypertension is a risk factor for atherosclerosis. Atherosclerosis is one of the causes of like ischemic heart disease per origin, because like per etiology, a coronary artery problem is how you have ischemia to the heart. So when you have a coronary artery problem, how does this happen? It happens through atherosclerosis, that you have the coronaries, like this is a coronary artery leading up to the heart, and you have this fatty streak build up, and you have like the atherosclerotic plaque right there, the fibrous cap that eventually, you know, ruptures and thrombosis happens, and you block the coronary. Yeah, and even without the rupture, just this stenosis of the coronary artery, you have a decreased blood flow to the heart, and it's already problematic. Depending on the degree of stenosis, you have different degrees of ischemic heart disease. The most extreme of which is when the rupture happens and thrombosis happens. The least of which is, I don't know, just like some mild stenosis. We'll cover that in a bit. We'll get back to that in a bit, but just let's confirm that we covered everything here. So ischemic heart disease definition, we have it. Supply and demand, we have it. Epidemiology, it is the leading cause of death worldwide by far. It's almost like it's the second place is cancers, and it's far ahead of cancers. Like maybe double as likely that a person will. It's not actually double, but it's almost double as likely that a person will die from heart disease than he would die from cancer. So yeah, do your exercise, good students, and you know, stop eating fatty foods, stop eating too much sugars, you know. Yes. Anyways, so risk factors for atherosclerosis, we covered hypertension. Hypertension is the core. Smoking is a very big one as well as dyslipidemia, so increase in LDL, a decrease in HDL. And diabetes is also a big player as well. Yep, that is it for the most part for definition, epidemiology, etiology. Now, deep-seated pathology and pathogenesis and classification. Before we get to that, I'd just like to cover a quick anatomy point that, how do we do this? Yeah, just remove these, make the person healthy again. Yes, so the supply of the heart with blood happens through the coronary artery. So you have the aorta spreading up right out of the left ventricle. Right outside the aorta, like right above the aorta, you have the aortic isthmus. The isthmus is where the coronary arteries bud off of. These coronary arteries bud off of. They are the left coronary artery and the right coronary artery. Okay. So far you have these two coronaries. The left coronary artery very soon splits into the circumflex artery, the left circumflex artery, and the left anterior descending, the LAD. Okay, so this is circumflex, it goes towards the back, and the LAD goes like that, this one over here. Yeah. So all in all, the left coronary artery it very soon splits into these two branches. So clinically, we say that there are like three main branches of the coronary artery. Clinically, we speak about the circumflex artery, the LAD, and the right coronary artery. What do each of these supply? Well, I have this very wonderful drawing right here that I sort of painted up. Like I didn't draw the heart, of course, but I did the coloring. Yeah, good coloring. Okay. Anyways, so the LAD covers the anterior wall of the left ventricle, the anterior wall, and the anterior part of the septum. Okay. So just to clarify, this is the left ventricle, this is the right ventricle, and this is the septum between them. Yeah. So this covers the anterior wall of the left ventricle, anterior part of the septum. The left circumflex, this was the LAD, left circumflex covers the lateral wall of the left ventricle, and the right coronary covers the remainder. So you got the posterior wall of the left ventricle right there, the posterior part of the septum right there, and the entirety of the right ventricle. Yeah. So that is the coronary supply. This is quite important to know because when you have a person with a myocardial infarction, you gotta like understand like where it's happening through ECG, and then from that you can sort of as well get an idea of which coronary artery is blocked, so that when you do an intervention to free that blockage, of course you're gonna do angiography, etc. But to free that blockage, I don't know, it's sort of a good idea to have like which artery supplies which, just to have a general idea. But of course, you're always going to do angiography. We'll get to all of that in a bit. Some of that might have flown above your head if you're not familiar with what I'm saying. So I'll just continue. Anyways, now let's go to pathogenesis. So pathogenesis of ischemic heart disease, like I mentioned, it is through ischemia of the heart by blockage of the coronaries, mainly through atherosclerosis, and we mentioned it already. And now there are different degrees or different forms of ischemic heart disease. One of them is stable. One of them is angina pectoris. Angina pectoris literally means like chest pain. Okay, this chest pain, it develops due to a limited stenosis, so it's above 50%. I think the number is 50% stenosis of a coronary artery. The clinical manifestation, let's just jump to that, is a severe crushing pain. Okay, it is a severe crushing pain. That is literally angina pectoris. Typically radiates to the left arm or the jaw, and that is, I just wanted to mention that point about it. So this is what angina pectoris is. There are different forms of angina pectoris. A stable angina pectoris is one where if you take a certain drug, it's called nitroglycerin. Nitroglycerin dilates the coronary arteries. So nitroglycerin should be able to ease the pain because it dilates the coronary artery. Let's just so it would be wider. If it's wider, the stenosis is less present. Stenosis is less present, and so better supply to the heart, and you're better, okay, or you feel better anyways. So this is not a causative treatment. You haven't treated this atherosclerotic plaque, but what you have done is symptomatically averted the pain. So that is called stable angina. It is an angina which you can fix up by having some nitroglycerin, and the stable angina as well happens upon exertion and improves upon rest. It improves a bit upon rest. Just stopping for a while, it can improve the pain to some extent. Of course, you should nitroglycerin is still taken. Unstable angina is one that can even happen at rest, and it's one that is not improved by nitroglycerin. This is quite dangerous, or it lasts longer than 20 minutes. Stable angina typically lasts less than 20 minutes. Unstable angina can last even longer than 20 minutes. There is one more form of angina. Oh dear. Yeah, there you go. There's one more form of angina which is known as Prinzmetal angina. Okay, so Prinzmetal angina is where it's not, you might not even have atherosclerosis, but the coronary arteries just go like whoa, they just spasm. Okay, so like it would look something like this. It would just look like that. Like that. So it's just momentarily, for a moment, it just spasms like that for however long, and this causes the symptoms of myocardial ischemia. It can be quite serious. It can happen at rest. It can even happen during sleep. The reasons for it are not well known. As well, it's not very common. It is on the rare side, at least, especially compared to the other forms of angina pectoris. Every other 40-year-old has one of these. You know, this stable develops into unstable. By the way, stable is like a milder stenosis. Unstable is a more severe stenosis, or perhaps a bit of the plaque has ruptured, etc. A bit of thrombosis is formed, is quite narrow, etc. This is unstable angina, and thingy is not nitroglycerin is not helping it. The next layer, the next level is myocardial infarction, in which you have a full-on blockage of the coronary artery, and the heart is screaming for blood. Okay, so a full-on blockage of coronary artery, it's not going to look like that, of course. It's going to look like that, and the plaque is ruptured, and you have thrombosis on that plaque. Yeah, because of exposure to thrombogenic material. And yes, so this would be a myocardial infarction. And yes, so that would be a myocardial infarction. The heart is dying out, and you'll have these bunch of complications. So when a person has a myocardial infarction, they very well might just die. They had a heart attack, and without treatment, they very well might die. So you got to do something about that. Nitroglycerin definitely won't help. The whole thing is blocked up. Widening it a bit won't really help. So what do? You have a bunch of problems. You have a bunch of possibilities. Let's take one of the pictures of this. Okay, so what is it? Oh. Wait, no. Yes, so one possibility that you could have is that, so let's say the LAD is the one that got blocked. LAD is the most common artery that gets blocked. So if the LAD is blocked, what do? The treatment option that you have is that you go to angiography. Angiography is basically a procedure in which you inject a contrast medium into the body so that you can visualize the contrast go through the coronary arteries. Okay, you'll see it go perfectly fine through all the coronaries except for this one. It won't pass by, or it's gonna be very thinly passing by. This is gonna be this will tell you that the problem is here. How do you solve it? It's called percutaneous coronary intervention, PCI, in which you insert a little guide wire over here, a little small balloon, you put through the area of stenosis, and you just pump up that balloon. It goes plop like that, and it smushes the plaque and the junk, the thrombus. It slushes it onto the walls. Okay, and to keep that like that, to keep that to stay there, and so that it just doesn't just return back in place, the balloon is surrounded. The balloon looks like this. The balloon is surrounded by what is known as a stent. Okay, you know what a stent is, maybe, right? Like a metal meshwork sort of thing. Okay, this meshwork is left behind when you pump up the balloon like that, and the stent is left behind. The stent keeps the artery patent, and yeah, you have thusly treated the patient. Of course, the person's heart has already died up a bit, and so you might have a part which is like all grayish yellow, whatever, and that part won't be able to pump blood. We'll get to the pathology of it, the pathoanatomical findings of it right away, as well as the clinical features, as well as the complications. Those are 3 points that we'll cover. I think we'll do that right away. So where are we? Yes. Here's some morphological changes, sort of as pathoma. Very wonderful table describing it. You, depending on who you are, you may very much need to know this sequence, like for pathology examination. Depending on it's ranged from the time of infarction, and you have the gross changes, microscopic changes, and as well, the complications we'll mention separately. But yeah, do take mental note of this table, or a screenshot of this table if you need. This you will definitely require. To save up time, I will not necessarily read off the table, because I'm sure you have reached this far in medicine. You're probably literate, so you're probably able to read it yourself. Anyways, so now to mention clinical manifestations of ischemic heart disease, and then we'll focus more a bit on myocardial infarction. So we mentioned severe crushing chest pain. but 20% are painless. 20% are painless. Why could this be? How is it that ischemia is typically a very painful event wherever it happens in the body? How could it be that such an event would be without pain? Well, if you recall, one of the risk factors for atherosclerosis and the development of ischemic heart disease is diabetes. And diabetes, one of the results of diabetes is neuropathy, like glucose glycates the sensory nerves, and so there are some parts of the body that are going to be a bit more numb. You'll have sometimes like numb toes, things like that, and therefore a person could just bruise their toe or cut their toe and they wouldn't even notice it, and you develop an infection in that foot, etc. Blah blah blah, diabetic foot. It goes along that line. That was ultra simplified, not entirely accurate, but it's the gist of it. Diabetes, likewise, it may affect the sensory nerves going to the heart, so that you could possibly have a myocardial infarction and not even notice it. You'd have the rest of the symptoms, but you might not feel the chest pain. So the severe crushing pain, pain radiates to the left arm or to the jaw. In myocardial infarction and unstable angina, it is not relieved by nitroglycerin. Other signs you could have, signs and symptoms, include dyspnea and include signs of shock. So you have tachycardia, hypotension, a cold sweat, nausea, vomiting, and loss of consciousness. All of these are possible. So these are clinical features of ischemic heart disease. Now, continuing onwards to myocardial infarction, we spoke about so far it's deep C, like the definition, epidemiology, etiology, pathogenesis, and some pathology, pathoanatomy, clinical manifestation. Now I just want to mention a side point before we get to diagnosis and treatment. I'm going to mention the other two kinds of ischemic heart disease, plus the complications of myocardial infarction. Hey, guess what? I got another mnemonic for you. Darth Vader. Okay, the Darth Vader. These are the complications that you can develop from myocardial infarction. Death, first off. Okay, arrhythmia is another one. Because of the ischemia, the electric system of the heart could also go whack, and you could have an arrhythmia. Sometimes a very, very dangerous arrhythmia, which might even lead to sudden coronary death. A sudden death of the patient due to electrical reasons. Yes, so you don't want that. Anyways, the next point is arrhythmia rupture, because if the ischemia happens on a wall of the ventricle, let's just open this one. Okay, if the ischemia happens somewhere over here, all right, LAD. If an opening over here happens, the blood could just seep out. It could rupture, okay, or the rupture could be here, and you'd have a connection between left and right ventricle, and that's also going to be a big problem. And we're going to get to that towards the end of the lecture, the connection of left and right ventricle. We're going to reach that towards the end. Anyways, you could have a tamponade, because the rupture, instead of like I mentioned, instead of going from like over here, rupture of the ventricular septum and the connection between the two ventricles, it could be out here, and the blood won't go outside the body. It'll go out into the pericardium, and when the blood goes into the pericardium in such an acute situation, you'll have tamponade. So the blood outside of the heart, the blood that is surrounding the heart, is now limiting the heart's ability to fill up with blood on the inside, like because of the constricting effect of the sac outside of the heart filled with blood. You're running out of room, so you're not able to fill the ventricles properly, and you might have heart failure due to that, because this is called an obstructive reason of heart failure, and an obstructive shock is what would result. Okay, you would go into shock and you would die because your heart is not able to fill up properly with blood. A diastolic heart failure, yes, because the heart is not able to fill up with enough blood during diastole. So That is tamponade. Heart failure, we'll get to in a second, but yes, if the heart is not able to, and we've mentioned it already extensively as well, if the heart is not able to contract properly because it is dead, or a part of it is dead, therefore you're going to end up with a heart failure, forward and backwards failure. Forward would lead to deprivation of the kidneys of blood, so they would fire up the RAS system, so this would lead to hypertension, or higher hypertension, would lead to as well retention of fluid. This retention of fluid makes the heart failure worse, so it's one hell of a ride. That's heart failure. That was a quick revision as well for you. Valve disease, because the rupture could instead happen in the valvular system of the heart, and so like one of the valves could go like kaput, and so the valve could be insufficient, and the insufficiency of the valve could cause severe problems as well, including heart failure. Valve disease, aneurysm of a ventricle, because if the ventricle is not ruptured, but because of its nature now, it is dead muscle, it might just like baggage outside, like, you know, and you would have an aneurysm of the ventricle. And this aneurysm as well, it might not look like that, it might not look like a dude's ear or something, but it could be just like that, like, you know, this aneurysm, because blood might just accumulate in that sac, it might thrombose, and that thrombosis could actually launch an embolism outside into the body and clog up, and it's an arterial embolism, which is very dangerous. Plug this into the brain, into the vasculature of the brain, and you got yourself a stroke. Plug it into the kidney, and you got renal failure, etc. Very problematic. Or into the bowel, and you've got bowel ischemia. So very not nice. So that is as well the point of embolism. Please work. Embolism, and this is due to a mural thrombus. Yeah, an embolus due to a. How do you work this? Yes, there we go. Yes, embolism due to a mural thrombus, which typically results from an aneurysm from the ventricle. I'll mention this in just a sec. Mitral regurgitation we've covered. Recurrence, obviously this is yeah, it might just happen again. And Dressler syndrome is focus on it, is a post-myocardial infarction pericarditis. It is a pericarditis, like an inflammation of the the sac of the heart after myocardial infarction. For whatever pathophysiological reason it happens, it happens. These are the complications of myocardial infarction. You know I'm going to stuff you with mnemonics. This new one is Darth Vader. Very nice. This is its own final question in a few final exams, so it's pretty nice to know. It's pretty nice to have a one single mnemonic for a whole final question. Oh, that was local for HK, so sorry for those listening outside. Anyways, it's cool. Next up, whatchamacallit. Next parts of ischemic heart disease. We've already covered sudden coronary death. This is when post-myocardial infarction, typically, you would have this development of an arrhythmia. A very dangerous form of arrhythmia is ventricular fibrillation. Ventricular fibrillation is when the ventricles are freaking out. Yeah, I can do it in one button. Very nice. Okay. So when the ventricles are freaking out, they're like pumping like crazy. These ventricles are rather not pumping like crazy. They are twitching like crazy, okay? You would have a ventricular rate of like 300 or something like that, okay? This is crazy, 300, 350 even. I don't know, it's gonna be crazy. It's not, these are the electrical impulses that are going on, but it's not actually producing any pumping of blood because you didn't have a full chance to even fully contract, you know? So it's just twitching in place, and so blood doesn't move, and so the body is like, and it dies. So that's not nice to have, to say the least. So that is sudden, where's the slide? Yes, sudden coronary death. Chronic ischemic heart disease is a person who survived a myocardial infarction, typically. Like a person after myocardial infarction is in the situation of chronic ischemic heart disease, which is basically low-key symptoms of heart failure after myocardial infarction. This is pretty much who a chronic ischemic heart disease person is. This person has a scar on the myocardium. He's more sensitive to ischemia. He's got some necrosis on his heart. Yeah, I already covered that. And yeah, not a nice place to be, but at least he's not dead. So This is a continuation. There aren't 4 separate diseases. They are all connected to one another. So an angina patient will start off stable, develop into unstable, and may end up getting a myocardial infarction. This MI patient might at any point develop sudden coronary death, or he will become instead a chronic ischemic heart disease person who will still eventually possibly develop sudden coronary death. So yes, that is in the gist of it. Deep sea, and now we're gonna cover deep-seated diagnosis and treatment of ischemic heart disease. We already covered PCI. PCI. There is one more surgical treatment. This is an interventional radiology method. Interventional radiology method of treating myocardial infarction. We covered this. So the other way that you could treat like a blockage of an artery, of a coronary artery over here, okay? Or rather, this is more typically done not in the case of a single block like that. Like the following is done more when you've got a severe stenosis, like you've got unstable angina in more than one coronary artery typically, or something like that. This is typically the indication of it, like a not complete stenosis, but quite the stenosis of more than one artery, or a wide stenosis. Like it's not just a pinpoint stenosis; it's like a stenosis that goes on for a while. Like all of this is stenosed, but it's not enough to cause an MI or whatever. What you do is a surgery, and so the method is called cabbage. And this is where you take a cabbage and you use it on the coronary. I'm joking. So this is where a cabbage is coronary artery bypass graft. Coronary artery bypass. You bypass the coronary graft. Graft is a some other vessel, okay, or some other tubing, okay. So you take a vessel. Typically, is going to be the mammary arteries. Or you instead take the vena saphina magna, greater venous vein, okay? And you take that and you plug it, you plug it in there and you plug it in there, before and after the stenosis, so that when blood flows through the aorta, it finds the stenosis, it goes to the path of least resistance. Over here, it goes through here, and it just bypasses the stenosis, yeah? So you take that vessel, you plug it in the beginning of the coronary, before the stenosis and after the stenosis. And therefore, you have bypassed the problem, yeah? So that is the surgical approach of treating a myocardial infarction. How about ischemic heart disease in general, outside surgical, outside radiological intervention? You have, for the treatment, diagnosis. How do you diagnose it? You got ECG and you've got the lab test, the blood test, troponins. Troponins are are found in cardiac cells, cardiac muscle cells, and yeah, they will be released in the blood upon damage to the cells. So the changes you're looking for are changes on ECG or the release of troponins. Thus, that is the diagnosis. If you want to diagnose further than that, you would do a coronary angiography. And if you find there is indeed a stenosis, you would either do PCI or you would do a cabbage. Yeah. Yes. So outside of this, so if the person's just got finished with having a myocardial infarction, okay, and he is alive, and you give him PCI and he is alive, or you give him a cabbage and he's all good. So drugs. How many? What drugs do you give him? Time for another mnemonic. Monabash. Okay, Monabash. Morphine, oxygen, nitroglycerin, aspirin, beta blockers, ACE inhibitors, statins, heparin, clopidogrel. Okay, I'm going to simplify this. You're not going to need this for pathology studies. You're going to need this for pharmacology and internal medicine. Okay, morphine is plus minus, but it does help to alleviate the pain, helps to alleviate the stress of the patient. But does it improve life expectancy? Plus minus, it might even reduce it, but it's nice to have. Oxygen is good, but also plus minus. Nitroglycerin, indeed, it is needed, but the core of the Monabash is the Abbas right here, the Abbas right here, and that is aspirin, beta blockers, ACE inhibitors, and statins, plus clopidogrel as well. Clopidogrel is similar to aspirin. It's called dual antiplatelet therapy. Aspirin is for antiplatelets, so you have less chance of coagulation. Clopidogrel is also antiplatelet, so you use both. Beta blockers is so that you reduce the heart's activity so that it would be easier on the heart in the long term. Okay, so this is beta blockers. ACE inhibitors is to reduce to remove the RAS system activity, the RAS activity. Statins is to improve the dyslipidemia, and heparin is also maybe in the beginning you would give it. So that is Monabash. Yeah, so that is for the internal medicine part if you are interested. So that is deep-seated. We've covered it. Yes, we have finished ischemic heart disease. Take yourself a 0-minute break and we'll move right on. Oh, yes. Anyways, so before we continue, let's just take a quick bird's eye view of what we've covered so far. Definition of ischemic heart disease, it's ischemia to the heart. That's a disease. It's due to mismatch of supply or increased or increased demand of the heart. It is by far the leading cause of death worldwide. The main problem is coronary arteriosclerosis. Risk factors: hypertension, dyslipidemia, diabetes, smoking. The problem is that you've got a blockage somewhere. This is what the coronaries look like. This is what the coronaries feed. I gotta clean this up. This is what the coronaries feed. Do remember this is quite nice. This is the forms of ischemic heart disease, and they are a continuum. It depends on the degree of stenosis. The exception, of course, is Prinzmetal, in which it is a spasm, and you might even develop an MI, but it's all quite rare. This is the morphological changes. This is the clinical manifestation we have covered: chest pain, dyspnea, signs of shock. These are complications of a myocardial infarction. This is the diagnosis and treatment, deep-seated. And now we can move right on to the congenital heart diseases. Congenital heart diseases. I have summarized it in one slide. This is actually, some would think this would be the longest topic or something like that because of so many, really, there is quite the number of entities that fall under congenital heart disease. But the skeleton of the disease of this entity as a whole, of this umbrella term as a whole, it's very simple, or it's very uniform, So I'll just go through the deep-seated of it directly. So the definition of a congenital heart defect is, it is a congenital malformation of the heart. Epidemiology: 2% of newborns have it. What is it? It's a problem in the heart, some defect in the heart, some hole in between the atria and ventricles or something like that that's not supposed to be there, some problem with the structure of the heart. That's basically it. Some inborn problem with the structure of the heart. 2% of newborns have it. The etiology is multifactorial. It is either some genetic defect the child has, or there was some sort of insult during pregnancy. Some insults include smoking during pregnancy, alcohol during pregnancy, radiation during pregnancy, or that is basically it. So these are some main examples. Pathogenesis of congenital heart disease. You have two forms of congenital heart disease. They are the acyanotic and the cyanotic ones. The acyanotic ones are diseases in which, let me just get you a picture real fast. This is a heart. This is an absolutely normal heart. A cyanotic heart disease is one where there's, let's start with acyanotic. Acyanotic is one where the person ends up having no cyanosis, okay? So this, for example, would happen when there's, let's say, a defect over here, okay? There's a hole between, in the ventricular septum. The left ventricle has more pressure than the right ventricle, and so the blood would go like that, okay? Therefore, oxygenated blood is going backwards, is gonna go back into the pulmonary circulation, and right back, even more oxygenated, sort of, to the left ventricle and onto the system, onto the system. So it's no deoxygenated blood has gone into the systemic circulation. That's what acyanotic is. Cyanotic disease is when you have some connection or some problem in which the right heart, or in which this deoxygenated blood somehow finds its way into the systemic circulation one way or another. This could be, for example, due to severely increased severely increased pulmonary pressure. So severe pulmonary hypertension. Severe pulmonary hypertension leads to severe ultra heavy mega bulk strong right ventricle eventually, to a point where the pressures developed here are stronger than the pressures over here. As well, do keep in mind that the left ventricle during diastole, its pressure is going to be like ultra low, you know. So very easily, if there's a hole over here, you might have blood seeping through this way instead, and you'd have cyanotic blood, like deoxygenated blood going to the system, and you have deoxy blood, you would have cyanosis. The person, typically the baby, would be blue, and the blue baby would have problems with getting oxygen to his body, and he would sadly have problems staying alive. It could be fatal. So that is acyanotic and cyanotic. So acyanotic is typically left to right, because when the oxygenated goes to the deoxygenated area, it'll just come back to the pulmonary, to the lungs, it'll get oxygenated, go back to the left, and then eventually find its way back to the system. So there's no problem here. The right to left is very problematic, because you have effectively skipped the pulmonary circulation, you've skipped the oxygenation cycle, and so you jump straight into the system, into the left ventricle, which propels you into the system, and you have deoxygenated blood reaching the system, you have cyanosis, and yes. And so, as we'd covered, cyanotic congenital heart defects leads to not getting enough oxygen, and it can be fatal. Another point here to mention is that an acyanotic heart defect, we'll follow that loop in a bit, but basically, just in theory, it can lead to pulmonary hypertension. This is because blood from the left heart, very high pressure system, or like typically a higher pressure system than the right heart, very normally 5 times higher than the right heart, the blood from the left heart goes to the right heart. The right heart can't handle that pressure, and also it can't handle that increase of volume. Okay, so you have increased volumes looping into the pulmonary circulation, and this will lead to increased pressures of the right heart. These and increased pressures of the pulmonary vasculature. This will lead to right ventricular hypertrophy, naturally, and thus it will eventually lead to right heart failure and symptoms of right heart failure. Let's just enact that in this drawing. So, once again, if you have blood from, let's say there's just this gap over here, this is just a hole over here. Blood gets from left ventricle to the right ventricle. This blood is an increased volume, first off, okay? So this volume is going to make it problematic. If it was a massive hole, it might even cause dilatation of the ventricle, and the person would be, the baby would be dead instantly, like, you know. But if it's just and this is the case in a myocardial infarction, dude, where a rupture of the ventricular septum happens. If it's a massive rupture, like let's say like this big or something like that, it will lead to dilatation of the right ventricle, and the person would quite possibly die. However, let's say it's a smaller hole and blood is going to the right ventricle. This will lead to increased volumes, but due to this Frank-Starling mechanism, it will be able to handle it, of course with difficulty. The increased pressure and the increased volume that is getting into the pulmonary circulation and into the right ventricle is going to lead to this right ventricular hypertrophy, increased pulmonary pressures, which will also lead to right ventricular hypertrophy. So that's the acyanotic, cyanotic. That is there. I've scribbled so much, man. There's all this is going on here. One point here is that the acyanotic disease can actually develop into a cyanotic disease if the pulmonary hypertension gets too bad. This is called Eisenmenger syndrome. So back to the drawing. Where's the drawing? Where'd I go? Yes, there we go. So if the pressures become too increased over here, eventually with pulmonary vasoconstriction, with like increasing and increasing pressures, in the right ventricle, eventually, like over several years, it might eventually lead to reversal of the shunt. Like reversal, instead of going this way to that way, it might actually go this way to that way. It's very mysterious. You'd think, oh, but like, what's going on here? I thought the left ventricle is like, I don't know how many times. The thing is, like a higher pressure, etc. It can happen. Very much does happen. Eisenmenger syndrome, that the right ventricle might get so loaded with pressure that the left ventricle might actually be like not stand a chance against it. Like, you know, do keep in mind as well, during diastole, the pressure of the left ventricle is quite decreased. Like, you know, of course it would be that way as well in the right ventricle, but of course the desync between the ventricles, etc. All of these factors play a role in the possibility of this Eisenmenger. Yes, so that is the deep, and now we cover the C. It could be asymptomatic, like a congenital heart defect might be entirely asymptomatic, or it could lead to dyspnea because signs of right heart. It could lead to dyspnea. It could lead to cyanosis and signs of right heart failure, like we covered over on this point on acyanotic defects. It could also lead to dyspnea due to the backing up of blood into the pulmonary circulation. We'll cover all of that. Regardless, how do you detect these? You detect them with an echo. An echo is an echocardiograph. It is basically ultrasound of the heart, and the treatment is surgical. You just go in there and patch up what the problem is. However, some defects actually fix themselves on their own. It's just spontaneous repair. Yeah. So that is congenital heart defects. This is the general structure of them. Now, these are the defects that we're gonna cover. All right. These are the acyanotic ones, and these are the cyanotic ones. So ventricular septal defect, a defect in the ventricular septum. Atrial septal defect in the atrial septum. Patent ductus arteriosus. Ductus arteriosus is a connection between the aorta and the pulmonary arteries that is present in the fetus, and it is very useful for the fetus because you get the fetus gets to shunt blood away from the lungs, which aren't in full need of blood. It shunts it away, and it gets to the systemic circulation instead, because the blood is getting oxygenated by the placenta. That's where it's getting its oxygen. It doesn't really need all the blood to go to the pulmonary circulation. You remember? So that is patent ductus arteriosus. We'll cover all these in detail, but this is just a general overview. Coarctation of the aorta is when you have the aorta. I hope you have an aorta, by the way. You have an aorta and it has a narrowing, okay? A narrowing in it. This narrowing will lead to increased, and you have, of course, the branches before this narrowing. This stenosis over here in coarctation, this very strong stenosis, is an inborn stenosis, will lead to very much increased pressures in these in the upper part of the body, so the head and the upper limbs, because the brachiocephalic trunk feeds the brachio and the cephalic, the head and the arms. So this leads to increased upper limb and head, upper limb pressure, and decreased pressure down there. So decreased pressure in the lower limbs. When you measure the blood pressure with a blood pressure manometer, this is what you would find: discrepancy between the blood pressures. How does blood get to the lower limbs then? There are various ways. We will tackle all of it in due time. Although I don't think it'll be covered in too much detail, because for pathology you won't need too much. I will cover it to a certain extent. You will get more of it in surgery, in pediatrics, in internal medicine, so don't you worry. Anyways, the cyanotic ones are tetralogy of Fallot and transposition of great arteries. These are these have too much content for me to just cover them in a gist like that. Anyways, VSD, all very simple. Let me just remind you once more. Is there just like a one button clean? Oh, is this an eraser? Oh wow! I wish I could. I wish I had this in the beginning. Okay. Wow. Okay. Did not see this eraser. Anyways, I'm new to this drawing tool on PowerPoint presentations. Anyways, so the like this, you learn this, okay? Because this is applicable to all congenital heart defects, okay? This general framework is present in all of them. And now I'm just going to give you very small details about each particular one of these defects. But this skeleton, the structure, is the same in all of them. Like D, E, E, PCD, all of it, deep-seated is all the same. The only slight differences is going to be whether it's cyanotic or it's acyanotic and where the defect is. But other than that, everything else is the exact same. So a ventricular septal defect you have right here, very nice drawing, where you have the hole in the ventricular septum. So the blood goes normally through the aorta. It also goes through this ventricular septal defect, the defect in the ventricular septum, and so it will go through to the right ventricle, and now the right ventricle has some oxygenated blood in it as well. It's left to right shunt, left to right, yeah, left to right. So there's no problem, no cyanosis will develop. This blood, which gets over here, is going to become even more oxygenated through by the lungs, and then it enters the left atrium, and the left atrium is nice and red. There's no problem here, and all the blood that's going to the system is all red. It's all good, okay? Eventually, where'd I go? Yeah, eventually, however, see, it's leading to like these increased volumes are stretching up. The ventricle is leading to a volume overload, leading to a pressure overload, leading to hypertrophy. You see the thickness here, the thickness there, and increased pulmonary circulations. Eventually, you could even have the case where you have reversal of flow, and this is, what is it? What's it called? It's called Eisenmenger syndrome. And so you have the blood from the right heart. The right heart has developed such a high pressure that the blood is actually going backwards, going right to left shunt. So this shunt is going back from the right to the left, and you have now blue deoxygenated blood going into the left ventricle, and left ventricle is going to shoot it right into the system, and now you're going to have cyanosis. Yeah, so that's Eisenmenger syndrome right there. That's all we're going to cover. VSD. That's all there is to cover, really. It's very simple. ASD, atrial septal defect, is a defect in the atrium. Everything, the same thing applies, but the hole is in the atrial septum instead. Blood goes to the atrium, oxygenated blood. So same thing happens over here. No problem because it's left to right. There is going to be increased pressures, so you're going to have increased pulmonary increased pulmonary. You're going to have pulmonary hypertension. You're going to have right ventricular hypertrophy. You might even have symptoms of right heart failure. That's also the case for VSD, by the way. You might have symptoms of right heart failure because the heart can only manage so much. And then eventually, when the pressures are so high, you could eventually have a reversal of the shunt, and you would have the same situation, very similar to VSD. The one extra point that I would cover is that there's something known as foramen ovale, okay? I'm sure you're familiar with foramen ovale from histology embryology. And this is a hole which naturally exists during the fetal period, and it's necessary for fetal circulation. And it's supposed to close very early after birth. What if it stays open? If it stays open, you're going to have... depends on the size of it, but you might not have any symptoms at all, especially if it's small. Since it's between atria, by the way, atria are like low pressure systems. There's not too much tension going about. Like this left to right shunt isn't that severe. Like, you know, unlike VSD, especially a large VSD could be quite problematic. But a foramen ovale, patent foramen ovale, guess how many people have a patent foramen ovale percentage? It's very likely you have one, actually. The percentage is up to like 25%. So like 1 in 4 of those watching has a patent foramen ovale. Interesting, isn't it? This poses no problems typically. You could go your whole life asymptomatic, no problem. Because, like I said, the atria are a low pressure system, so this shunting isn't actually that big, isn't that bad anyway, because they've got such low pressures themselves anyway, so barely any blood is actually moving between them. The next point I'd like to mention is that this patent foramen ovale, what the problem may occur. Remember when we talked about DVT and how in a DVT you could have let me get the picture. In a DVT you could have the thrombus go all the way to the pulmonary circulation and clog one of the Some of the, like if it's big enough, it could clog the whole pulmonary circulation, and you're gonna die instantly due to dilatation of the. You have a dilatation of the heart. That's not the cause of the death. The cause of the death is acute right heart failure, and if the right heart fails, no blood is flowing, no blood is flowing, no blood is forward failure, backwards failure, you're dead. Anyways, so what about what if you had a patent foramen ovale? You had a hole right about here, okay? What could happen is this DVT. Side point. If it was a small thrombus, it might just get lodged in the small vessels. No big deal. Might, if many of them happen over the years, you will have increased pulmonary pressure. Yeah. Anyways, if you got a patent foramen ovale, it's possible that a small thrombus might actually make its way through, instead of going through the pulmonary artery, it might actually slip through the patent foramen ovale, go to the left ventricle, and go through the aorta. This is catastrophic because now it could end up anywhere in the system, like, you know, and if it ends up anywhere in the system, know for sure that you're gonna have problems. You're gonna have ischemia. It's not venous like problem where, like, it's not some side branch over here of the pulmonary vessel where it's just gonna shunt away from it anyway, and no problem. No, it's gonna end up, for example, in a kidney, and the kidney won't have some part of the kidney won't have supply, and it's gonna go ischemic. It might have renal failure, or it blocks a part of the gut, and this is gonna be very problematic as well. Gut ischemia. And you could die from that. You could die from like necrotic bowel, and bacteria escape from the bowel. You've got bacteria all throughout the body and junk through the blood, and you got sepsis, and you're shock, and you're dead. Very possible. So not very nice. As well, it could end up in the brain, and sorry, wrong way. It could end up in the brain, and the brain doesn't like having not oxygen. It likes having oxygen very much, so without oxygen, you're gonna die, once again. So patent foramen ovale, this is called a paradoxical embolism. Paradoxical embolism, yeah? All in all of it is not very common, but yeah, worth the mention. Just in case you're asked, you know, it is a reasonably common question if such a thing, if you're asked to talk about such a topic. Patent ductus arteriosus. So this is where, remember when we talked about the ductus arteriosus, that it is a small connection, a shunt between the aorta and the pulmonary arteries. Normally, this is open during the fetal life because the fetus needs it for its circulation, because it wants to shunt blood away from the lungs, because the lungs aren't doing anything for it, and lungs get enough of what they need. The fetus is not in need of blood going through to the pulmonary arteries, so it shunts, like quite the amount of blood is shunted through. Like in a fetus, it goes this way, like from the pulmonary arteries right through to the aorta and through to the systemic circulation, to the limbs. Okay, so what if this remains open? When if it remains open, it's supposed to close right after the baby is born, okay, or shortly after, like within a day or so. What if it remains open? If it remains open, then we've got a bit of a problem, because now the shunt is going the opposite way. First off, so the blood goes from the aorta left to right. It's left to right. So so you don't have cyanosis. So it goes from the aorta to the pulmonary arteries. Of course, the blood will continue to the system. Some of this will continue to the pulmonary arteries, to the lungs, oxygenated, back into the atria, back to the left ventricle, and back to the aorta, and back to the system, or it continues back into the pulmonary artery. So, with that, the problem here isn't what's been mentioned so far. The problem is that now you have an increasing blood flow to the pulmonary arteries, and this is causing an increasing flow to the atria, okay, to the left atrium and left ventricle. This is now causing, actually, you'd think it's left to right, but left to right, and the pathology ends up first happening in the left ventricle, actually, you know. So the left ventricle actually gets hypertrophic because all this excess blood, it's ending up back into the left atrium and back into the left ventricle. And so this is going to cause left ventricular hypertrophy, left ventricular hypertrophy, and increasing size, increasing of, now the ventricle is more sensitive to ischemia, etc. But it's once again, it is not all that bad anyways. It's not severe, it's not critical, you know? It's not so bad. However, what it will cause is that you have an increasing pressure in the pulmonary vasculature, because you're gonna have, again, once again, you have increased blood flow to the lungs, increasing blood flow to the lungs, so increasing pressure to the lungs, to the lung vasculature, and so this is gonna cause problems for the right ventricle. Yeah, gonna cause problems for the right ventricle. That's why you see this drawing progressing in this way, like normal, then left ventricle, then right ventricle also has problems. Yeah. So that is that. I like these drawings, I gotta say. Glad I was able to find them. Big kudos to the one that has prepared these. The next up is coarctation of the aorta. Like we already covered, is a congenital stenosis of the part of the aortic arch, increased blood pressure on the parts before the stenosis, decreased blood pressure on the parts after it. How do you actually end up feeding the lower limbs then, etc.? You know, well, there's collaterals that exist that basically one of the branches that result from this upper part is intercostal branches which go to the between the ribs. These branches will end up getting, I'm simplifying it, you will, like, these branches are connected, receive blood from up here, and other branches of the intercostals receive their blood from below, this area. So therefore you would have blood getting from above the stenosis to below the stenosis. Therefore, you'll have an increased amount of blood going through the intercostals. The intercostal arteries might become very wide as a result of these, like, massive gorged intercostal arteries, to be able to feed this area below the stenosis. Another possibility is patent ductus arteriosus. If it is patent, there's the possibility that some blood will actually end up going to the this area. I don't want to necessarily go into too much detail because I don't think it's too necessary for you in the stage. But long story short, patent ductus arteriosus can also be of help in fixing this problem if it is present. Coarctation of the aorta can indeed, if it's severe, it can be fatal. So this is a problem. But yeah, that is the gist of it. And these are the acyanotic. We have covered them so far. And for quite a few of them, like VSD, even ASD, you may have development, especially for VSD, you may have development of a cyanotic instead heart disease due to Eisenmenger syndrome. And now we're going to cover the cyanotic heart disease, and we've got tetralogy of Fallot. So tetralogy of Fallot, tetra means four. There are four problems which are happening here, okay? So what are these four? You have pulmonary artery stenosis, you have right ventricular hypertrophy, you have VSD, and you have an overlaying aorta. The aorta does not come out of the left ventricle, but it comes out in between the left and right ventricles, okay? So that is the tetra, okay? So the mnemonic right here is R-VOTO, and it is right ventricular outflow tract obstruction. Right ventricular outflow tract obstruction, which basically means stenosis of the pulmonary valve. Yeah, so right ventricular outflow tract obstruction, okay? So, and then you have RVO of the R-VOTO. RVO, R stands for the right ventricular hypertrophy, V is for VSD, and O is for overlay of the aorta. So overlying aorta, you see the aorta right here? It is plugged into both the right and left ventricles. Yeah, so this is tetralogy of Fallot. It is a cyanotic heart disease because of this VSD. So that is the gist of tetralogy of Fallot. These are the content of it. It is a cyanotic heart disease because of the VSD, and you'll have thusly unoxygenated blood going through. 2 points I'll mention regarding the tetralogy of Fallot is that one is that it is cyanotic. What happens here is that when the baby is getting cyanotic and he is not liking it, develop a certain action which helps them get beyond the cyanosis. They squat. They squat. So when they squat, this increases the systemic pressure. Okay, the blood pressure. This increase of systemic blood pressure momentarily will cause a reversal of this shunt. He is cyanotic because blood is going from the right to the left. Why is blood going from the right to the left even? It's because of the hypertrophied right ventricle and the most importantly the stenosis of the pulmonary valve. So increasing pressures here, the blood goes through here. Now instead, because he squat, it goes reversal. So the blood is going back to the right ventricle instead and is going normal. And these are called TET spells, okay? TET spells is basically tetralogy, spells, a spell of cyanosis which happens, which is aggravated by various reasons, crying, some forms of exertion, etc., will trigger this TET spell, and they squat to fix it. When they squat, this reverses the flow because of the increased pressure. It reverses the flow of the right to left shunts. It goes left to right instead, and this fixes up the cyanosis. The next thing I wanted to mention about tetralogy is the treatment. It's surgical. The main thing that you do is fix up the stenosis and close the VSD. And yeah, once again, that's not new, because the treatment for and of course, like, move what you can. The treatment for everything is for all of these is basically surgical, except for those that fix themselves. Lastly, last thing, is it truly last? Whoa! Thank God, we are actually reaching the end. Transposition of great arteries. I'm glad I got this picture from Osmosis. Really, guys, good sources for studying pathology, for studying internal medicine. Definitely, Pathoma. Number one, definitely. Number two is Osmosis. It is amazing. Number three, online med ed. Absolutely amazing source. Clinical, absolutely gold. I'm here anyway, so might as well give you advice, you know. Transposition of great arteries is that the pulmonary artery is in the wrong place. The aorta is in the wrong place. Pulmonary artery is coming out of the left ventricle, and the left ventricle, with its high pressure, is pumping to the lungs, and then from the lungs it returns back to the left atrium. Left atrium, left ventricle, pulmonary artery, lungs. You see that there's a big problem here, right? This is perfectly oxygenated blood, but it's not going anywhere. It's not feeding anything. Likewise, you have the aorta coming out of the right ventricle, and so aorta blood comes out of the right ventricle to the aorta, to the system, back to the right atrium, back to the aorta, back to the right ventricle. Instead of going to the pulmonary, it goes back to the aorta. You see that there's a big problem. All the oxygen is over here, no oxygen is over here. So this is a massive problem, and this defect is not compatible with life, except if there is some connection between these two systems, either in the form of a VSD, or a patent foramen ovale, or a ductus arteriosus, a patent ductus arteriosus. Without the presence of at least one of these defects, the baby will not survive. So this is very problematic. The treatment, of course, is going to be surgical. And that is pretty much it for congenital heart defects. These are the ones we're going to cover. These are pretty much the most important ones, or the most frequently asked about ones. And that is pretty much it. We have reached the end. And I've got a bonus mnemonic for you, since you stayed for so long and you were patient with such a long video. Because you know how it is going to be, is that basically you know that I'm going to feed you with mnemonics as much as I can. You know that every chance I'm going to get, I'm going to stuff that into you. So since we are here, here's a bonus mnemonic for you. It is that when you have a night shift and you have to watch over patients till midnight, okay? When you have a night shift and you have to watch over patients all the way till midnight. Midnight patient videos. This mnemonic is for the etiology of all things. The etiology of anything, you can get it from this mnemonic. Very useful mnemonic, because you're thinking some disease, okay, like whatever disease it is, you're thinking of what are the possible causes of it. Well, it could be any one of these. It could be metabolic, some like a derangement of electrolytes, whatever, or like metabolites, whatever. Inflammatory, some inflammation, which could either be inflammation here is more about autoimmune or something like that, or other form of inflammation. Here you've got infection, the other kind of inflammation. Degenerative, neurological, iatrogenic, trauma, psychogenic, like psychological problems leading to it, or it's just in the patient's mind sort of thing. Tumor, vascular, some kinds of drugs, or it's some specific system that causes it. So I don't know, like an ear or an eye problem or whatever it is leading to that problem. So it's etiology of all things, and also plus congenital or genetic. This also falls under specific. Very useful mnemonic. Once again, you know I'm going to put those in mnemonics, force feed you those mnemonics. So that is it for, this has been quite the ride. I hope it has been beneficial for you. I wish you all the best for your studies and have a nice day.